Hello everybody, my name is Delcy Morrison and my presentation is titled Algorithms of Oppression, Vaginal Birth After Cesarean or VBAC Calculator. First of all, I would like to review biomedicine and race. This is the theory that different racial or ethnic groups have differing levels of physical, intellectual, and moral development that distinguish them as superior or inferior. In medicine, there is a belief that there are differences in the rates of disease between races and that this is due to genetics. There was a policy brief published by the Institute for Healing and Justice in Medicine. This policy brief was co-authored by medical students and graduate student researchers who helped write the brief because they envision a world where the social construct of race is not conflated with biology and the health consequences of racism are acknowledged, addressed, and cared for in all of their forms. So according to the policy brief, there are higher rates of cardiovascular disease, renal disease, diabetes, stroke, cancer, low birth weight, and preterm delivery among people of color when compared to white people. Research has shown that healthcare disparities occur because of inequalities in power and socioeconomics and not because of genetics. Schools of medicine teach that some medical conditions are attributed to differences in racial genetics instead of teaching students how racism contributes to health disparities. Racism is present in the care of patients by using medical algorithms that use race as a factor in determining risk of disease. And race-based medicine teaches people of color that their bodies and communities are abnormal and broken, which increases stress and racist stigma. The effects of biomedicine on patients include that patients of color are being systematically misdiagnosed and undertreated due to the biological use of race in clinical guidelines and education. Race-based medicine teaches people of color that their bodies and communities are abnormal, deficient, and broken, and medicine creates an environment that is not welcoming and hostile for people of color. There is a history of systematic abuse and oppression of Black, Indigenous, and people of color in the United States in the field of obstetrics and gynecology. For example, OBGYN researchers conducted experimental surgeries on enslaved women and controlled the fertility of racialized minorities. There was also an issue of forced sterilizations of 20,000 women in state institutions in California. There were high rates of hysterectomy procedures performed on immigrants held in immigration and customs enforcement custody, and Black women have historically been more likely to undergo cesareans due to non-reassuring fetal heart tracings when compared to white women. Clinical algorithms are oftentimes used in medicine to determine diagnosis or treatment of patients. They are usually a sequence of clinical decisions. They can be written for any area of medical decision making that can be standardized, and they are also a guide for teaching clinical decision making to students. So the topic of this presentation is dealing with a VBAC calculator. And so what is a VBAC anyway? So a VBAC is a vaginal delivery in a woman who has given birth via cesarean section in a former pregnancy. So the woman would have had a cesarean previously and now she desires to try for a vaginal birth. And so patients undergo a trial of labor after cesarean, and that's also called a TOLAC. There are some complications related to VBACs. Complications include uterine rupture. Uterine rupture is the most severe complication that interrupts the blood flow from the mother to the baby, so can cause problems with the newborn as well. And it can also cause hemorrhage in the mother, so increased bleeding, and it requires immediate surgery. Other complications include uterine dehiscence, which is where the outer layer of the uterus remains intact, but the inner layers become opened, so they dehiss or come away from, and also an increase in maternal and or neonatal morbidity. There are some benefits of VBACs. So they include a decreased risk of complications in future pregnancies if you have a successful VBAC, and then avoidance of surgical recovery in the postpartum period. So it's much easier to recover for the mother from a vaginal delivery than it is from a cesarean. And then it's also beneficial because if a patient has multiple cesarean sections, complications can occur, such as postpartum hemorrhage, placenta previa. Placenta previa is where the placenta comes out before the baby, and then other placenta-related disorders. So one of the clinical algorithms used in the field of obstetrics is the vaginal birth after cesarean, or VBAC calculator. So in 2010, the National Institute of Health, or NIH, declared the increasing rate of vaginal birth after cesareans a public health priority. They also looked at the VBAC calculators that had already been developed, because the one I'm going to show you was developed in 2007, and they determined that the VBAC rate would increase because of utilization of these tools. So, like I said, this particular VBAC tool was developed in 2007. It was developed by the Maternal Fetal Medicine Units, or MFMU. It was designed to give patients an individualized estimate of their probability for a VBAC using 6 different factors, and users were given a predicted chance of vaginal birth after cesarean as a percentage. So the calculator is shown here. The 6 factors it looks at is our maternal age, looks at body mass indexed, or BMI, which is a calculation using the patient's height and weight. You see race there. However, the only 2 races that were included in this tool are African American and Hispanic. They look at any previous vaginal delivery, any vaginal delivery since the last cesarean, and the indication for prior cesarean, if it was arrest of dilation or if it was arrest of descent. There were a couple of concerns with the VBAC calculator. The first one was that the calculator was published with no instructions for physicians or patients. And so both were expected to figure out how to use, apply, and interpret the tool. Oppression was also recognized in the VBAC calculator. So specific to the VBAC calculator, Black and Hispanic patients had a 5 to 15% lower score than white patients, making Black and Hispanic women more likely to undergo more repeat cesareans than more clinically necessary. The calculator portrayed being white as less risky than being African American or Hispanic. And by including race or ethnicity in the VBAC calculator, they may become self-fulfilling prophecies. So a doctor may look at a patient and see that they are African American or Hispanic and automatically recommend a cesarean instead of giving them a chance at a VBAC. In regard to racialized assessment tools in general, racialized risk assessments can lead to diagnostic lapses if a provider fails to identify a disease presentation in a patient that doesn't fit into an at-risk racial, gender, or class category. It's possible that racism can shape perceptions and attitudes of clinicians and may influence how they counsel patients and their decision-making process during labor. And research has shown that racialized assessment tools can lead to discrimination, stressful interactions with care providers, unmet information needs, and a greater involvement of child protective services. Because of the identification of oppression in the original VBAC calculator, MFMU came up with a revised calculator in 2023. The calculator took out the factor of race and replaced it with treated chronic hypertension. The developers of the calculator used the same patient data that was used in the development of the first calculator to make the revised edition, and this is what the new tool looks like. So if you see here, it includes maternal age, same as the old one. It also includes BMI, which is that calculation between height and weight. It includes obstetric history, and then the arrest disorder indication for the prior cesarean, which was also on the previous calculator. And then you'll see there at the bottom that it included the treated chronic hypertension in place of the race section. Although the developers of the new calculator took out the most oppressive factor in the VBAC tool, which was the presence of race, the African American Hispanic factor, some would argue that the new tool is also oppressive. So, for example, the tool still contains the factor previous cesarean birth, and more Black and Hispanic women undergo unnecessary primary cesarean births when compared to white women. So having this as a factor on the tool can be seen as continuing past racism. Also, according to Rubashkin, the variables of BMI and chronic hypertension are shaped by structural and interpersonal racism. The theory that we learned in class that I found most relatable to healthcare algorithms was Noble's algorithms of oppression theory. This is the theory that technology and online algorithms replicate and reinforce racist and sexist beliefs. This is relatable to healthcare algorithms because the algorithms are based on a history of racial beliefs that different races are biologically different. A statement was released by 19 OBGYN professional organizations, including the American College of Obstetricians and Gynecologists, that acknowledged the injustices inextricably linked to the field of obstetrics and gynecology and the need to recognize all the contributions made, both willingly and unwillingly, by oppressed and marginalized persons. This statement is a starting point for the OBGYN medical community towards recognizing the history of oppression and racism in their field and actively working to fix it. Future work for the OBGYN medical community to help reduce racism and oppression in their field includes helping to ensure equity in access to VBAC supportive providers and hospitals, fostering informed decision-making after a prior cesarean, educating healthcare providers to focus on social history and be aware of how social and structural stressors perpetuate racial health inequities, and adopting the same standards and guidelines for diagnosis and treatment of conditions for all patients regardless of race. And here are my references. Thank you for listening to my presentation.